Good afternoon, everyone. This is Judy Burleson. I'm the Director of Metrics at the ACR, and would like to thank everyone for dialing in today for the webinar on the CMS Physician Quality Reporting System. We do have a full house today, so I'm going to jump right in. And also, we will keep the lines on mute for the entire session, but I encourage you to ask questions using the questions box on your screen. So we'll go ahead and get started. I will say that of those that registered, the majority have said that they have participated in PQRS, but there's a good number that haven't, so I'm going to go through some basics today. And there is a lot of material I do need to cover, so I will go rather quickly. But again, please ask questions throughout the webinar. So looking at the basics, what is the Physician Quality Reporting System? It remains a voluntary reporting program to submit quality data to CMS on Medicare Part B fee-for-service patients. And physicians and other eligible professionals are able to participate. EPs include other providers such as social workers, physical therapists, and other types of therapists. I'll just really quickly go through a history of PQRS. It was first authorized in 2006 under the Tax Relief and Healthcare Act as the Physician Quality Reporting Initiative, with the first reporting period in the last half of 2007. There were only there were 74 measures then, 2 for diagnostic radiology, and the program started with a 1.5% incentive. In 2008, the MIPA legislation continued the program, increased incentives to 2% for 2 years, 09 and 10, and began the initial phases of Physician Compare website. The number of measures increased by they almost doubled. There was a new one for interventional radiologists and a number of new ones for radiation oncologists. And CMS also added the Registry reporting function. In 2010, with the Affordable Care Act, the program was made permanent, and so CMS changed the name to Physician Quality Reporting System. The legislation continued incentives through 2014 and authorized CMS to begin imposing penalties beginning in 2015. The Act also required CMS to develop an informal review process for participants in the program and asked CMS to begin integrating the clinical quality reporting, the clinical quality measures reporting with the EHR incentive program and PQRS. The ACA also authorized the PQRS maintenance of certification additional incentive. There were no new additional measures for diagnostic radiologists added in 2010, but one was revised and renumbered. There was a new measure for radiation oncologists. So looking briefly into the future, it was my crystal ball, the American Taxpayer Relief Act of this past January, the fiscal cliff legislation, authorized CMS to begin looking at qualified clinical data registries and specialty society measures, specialty board quality initiatives as potentially meeting satisfactory reporting for the PQRS. At the same time, CMS had an RFI out seeking input on how they might use that type of quality initiatives for meeting requirements of PQRS and the EHR incentive program. And just step back to that slide, we should see how CMS proposes to begin implementing that in the rulemaking process this year. And to take a look at the last few years, current and the future incentives and penalties for PQRS, and pointing out that negative payment adjustments are possible in 2015 based on participation this year. The incentive and penalty amounts are a percentage of the total allowable Medicare Part B fee-for-service charges. So the incentive reached its max in 2010 with a 2% incentive for participation in PQRS. If someone has their phone on, could you please mute it? In 2011, the Maintenance of Certification Program additional incentives for PQRS began, and so there was a potential for a 1.5% incentive beginning that year, or in that year, 1% for PQRS and an additional 0.5% for MOC participation. This year, last year and this year, the PQRS incentive was reduced to 0.5% of total allowable charges. So with that combined with maintenance of certification participation allows for a potential of a 1% incentive payment this year and next year. Beginning in 2015 through 2017, that's as far as statute has authorized any of the programs, there is no PQRS incentive authorized. There is a payment adjustment authorized of a negative 1.5% in 2015 based on calendar year 2013 reporting, a negative incentive of 2% in calendar year in fiscal year 2016 and 17 based on 2-year prior reporting. And I will point out that although there is no PQRS incentive in 2015 through 2017, there is a potential for an upward adjustment with the physician value-based payment modifier, which is a topic for a different day. So some highlights of the PQRS in 2013. Again, I would like to point out that it is the base year for the 2015 PQRS penalty. CMS has added another mechanism for reporting called administrative claims reporting. I'll go into more detail on this in a few minutes. And that is strictly for avoiding the 2015 penalty. The group practice reporting option was expanded to allow registry-based reporting of any PQRS measure, and GPRO is not just limited to the web-based interface reporting that it has been in the last few years. So this does open up the group practice reporting option to many more specialties, including radiology. There were a number of measures retired in 2013, including number 10, CT and MRI reports, which was reportable by diagnostic radiologists. CMS has begun to structure the measures in PQRS according to the National Quality Strategy 6 priority areas. The domains that they use are clinical care, care coordination, population and community health, efficiency, safety, and patient-centeredness. And you can see on this slide several examples of measures reportable by diagnostic radiologists and where CMS has placed them in the measure domains. So which measures can you report as a radiologist? Basically, there are 8 measures for diagnostic radiologists, 11 measures and 1 measures group for interventional radiologists, 11 measures and 1 measures group also for radiation oncologists, and beginning in 2014, additional 5 measures that may be reportable by diagnostic radiologists. These measures focus on optimizing patient exposure to ionizing radiation, and primarily looking at CT exams. And we are determining whether these measures are reportable by radiologists based on the CPT codes in the denominators of the measures and those codes that radiologists typically bill. And here's the list of measures primarily reportable by diagnostic radiologists or nuclear medicine physicians. The last 3 on this list, cardiac stress imaging measures, may be reportable by some radiologists, probably not very many. And I would also like to point out that these measures are only reportable through registry-based reporting. Here's a list of measures potentially reportable by interventional radiologists. The measure noted at the bottom is a measures group, which includes 4 measures, and we'll cover shortly what a measures group is. This is the list of measures and the measure group applicable to radiation oncologists. And I forgot to mention initially that both the presentation itself, the slides, and the webinar will be available to you after today's presentation. Okay, so how do you get started if you haven't begun participating in PQRS already, or if you have, there are maybe a few other decisions you might want to look at this year. So that's the way to get started is several decisions that you need to make. You need to decide whether to participate as an individual physician or as a group practice. You need to choose a reporting mechanism. We'll go through this in just a minute. Choose a reporting period, and choose quality measures that are most applicable to your practice for reporting. For this year, 259 measures have been finalized, both individual measures and measures groups. So as an individual physician reporting PQRS, your reporting is evaluated at the tax ID National Provider Identifier level. There is no requirement for you to register unless you select the administrative claims-based reporting mechanism, which I'll go into detail in just a minute about. This is basically the only option for physicians in solo practices. And individuals within a group practice may choose for themselves which PQRS measures they wish to report. You don't have to report as the measures that other people in your group report. And looking at group practices, those are evaluated at the tax ID level only through the group practice reporting option. And for the purposes of the PQRS, CMS has defined a group as a single tax ID number with 2 or more eligible professionals identified through your NPI and who have reassigned their billing rights to the tax ID number. Benefits of participating as a GPRO: it may reduce some reporting and tracking burdens particularly for the staff involved in your group. If there are physicians within your group who can't report any measure in PQRS, they can avoid the penalty if your group chooses to report as a GPRO. And just to note that groups must self-nominate to CMS by October 15, 2013, so this year. So you need to choose a reporting mechanism. Those are claims-based reporting. An individual physician can report individual measures or measures groups through claims. And what exactly is a measures group? It is a CMS-specified group of 4 or more clinically related measures that have similar denominators. So you report all the measures in the measures group. At this time, group practices under the GPRO option cannot report through claims. They can also not report a measures group. Another option for reporting data to CMS is through a CMS qualified PQRS registry. Individual physicians can report individual measures or measures groups using a registry, and group practices can report using a registry, reporting individual measures only. In order to use a PQRS registry, you must be able to report at least 3 measures. And to note that there is cost involved with registry reporting. I'd also just like to point out here that the ACR has partnered with a vendor called CPTII for their PQRI Wizard product to offer a discount to our members. And you can find more information about the PQRI Wizard on the ACR website. Another reporting mechanism is EHR-based. Individual physicians can use an EHR to report 3 measures. Just as for a registry, you have to be able to report 3 measures in order to use an EHR for reporting. You also have to be able to report 3 measures that have been specified for EHR reporting. And of the over 250 measures in PQRS, only about 50 have been specified for EHR reporting. But there are several measures that interventionalists and radiation oncologists may be able to report through an EHR. So you have a choice of using a CMS qualified direct EHR, which you would submit information directly from your EHR to CMS, or you may use a CMS qualified EHR data submission vendor, and that's basically the same as using a registry vendor. You collect the data from your EHR, submit it to pass it to the data submission vendor, and they will report to CMS on your behalf. Just would like to note that in this definition of a qualified EHR, that is not the same as certified EHR technology for the EHR incentive program. And also, unlike the EHR incentive or meaningful use program, you cannot report a 0% performance rate on PQRS reporting through an EHR mechanism. So you have to report on at least 1 patient. The GPRO group practice reporting cannot use an EHR for 2013, but they may be able to use certified EHR technology in the meaningful use sense in 2014 to submit data to CMS. So the additional option that CMS has added this year for purposes only of avoiding the penalty in 2015 is the administrative claims-based reporting. Both individual physicians and group practices can use this option, and it is basically a set of primary care measures related to primary care services that CMS will calculate from claims that you have submitted. You do not need to submit quality data to CMS as you do for traditional PQRS measures. Radiologists may elect this option even if none of the measures apply to you. So in this case, a 0% performance rate is okay. You cannot obtain a PQRS incentive under this option, and as I said, it is in place only to avoid the 2015 payment adjustment for 2013 reporting. If you want to be analyzed under this option, you must proactively elect the option, tell CMS that you want to be analyzed in this option by October 15th of this year. CMS is designing a web portal to elect the option, and that should be available beginning July the 15th of this year. I'd just also like to note, if your group has decided to participate under the GPRO option and selects the administrative claims-based reporting option, then individuals in your group may still report as an individual physician and qualify for an incentive by reporting traditional PQRS measures. There are 2 reporting periods available. One reporting period is the 6-month reporting period, July through December, and only individual physicians that are reporting a measures group using a registry may select this reporting period. So basically that option is only available to interventionalists and radiation oncologists in 2013 because there is not a measures group that applies to diagnostic radiologists this year. All other participants of the program, whether they are individual physicians or group practices, must report a 12-month period for PQRS to be incentive eligible and to be eligible for the MOC additional incentives. So let's look in more detail how you would go about reporting using claims to report your quality data on measures. And just briefly, some of the benefits of claims-based reporting. It's pretty easy to get started. Claims-based reporting is readily accessible to all EPs as basically a part of your routine billing practice. You do not need to contact or contract with a registry or EHR vendor to submit your data. You can just start reporting quality data codes related to the measures on your claims when you submit them for reimbursement for the services. So to get started, you should discuss within your group how to develop an internal process to flag cases that are relevant to measures so that your billing or coding staff know which claims to add the quality data CPTII codes onto. So you would submit the quality data code on the original claims for Part B reimbursement for procedures that are relevant to the measures. You must include the individual's NPI on the claim, remembering that groups can't report using claims. The claims data, including the quality data codes, is sent to the claims history file. I won't go through this, but this slide you can use as a reference later on. It just gives you a visual of how the quality data information would be included on this 1500 claim form. So in talking about claims-based reporting, remember that we said that in order to use a registry, you must be able to report 3 measures. But if you don't have 3 measures to report, you can use the claims-based mechanism to report 1 or 2 measures if that is all that applies to your practice. So if that is the amount of reporting that you have done, at the close of the reporting year, CMS will assess your ability to report an additional 1 or 2 measures. If you have successfully reported 1 or 2 measures, that is, you've accurately submitted quality data codes for at least 50% of the patients or services that are eligible and relevant to a measure, then CMS will analyze your claims to determine if you could have reported another measure or 2. So the first step in that process is the clinical relation test. If one of the measures that you have reported is in a measure cluster, CMS will look within that cluster to see if you could have reported another measure in that cluster. And the measures in the cluster are related by a clinical topic or professional service relevant to that type of practice. And we'll go through an example on this in a minute. So if it is determined that you could have reported another measure in the cluster, then CMS will do a minimum threshold test on those measures that could have been reported based on the claims that you submitted. The threshold for reporting won't be less than 15 patients for a 12-month reporting period. So if you reported if you submitted a claim that has a service that is relevant to a measure on 3 patients, you wouldn't be held accountable for reporting that measure, and you would be incentive eligible based on the 1 or 2 measures that you did report. This is the diagnostic imaging cluster that is used in the measure applicability validation process. So there are only 4 diagnostic radiology measures in the imaging cluster. Other clusters to be aware of for radiation oncologists, there are 3 clusters related to cancer care, and there is a cluster on surgical care that interventional radiologists should pay attention to. This includes the perioperative care measures. So we'll go through an example then for the measure applicability validation process. So Dr. Alexander accurately reported the quality data codes on measures 146 and 225. Those are both screening mammography-related measures for 50% of his cases in 2013. So CMS will look at all the claims that Dr. Alexander submitted through 2013 to see if he could have reported measures 145 and 147 because they are also in the diagnostic imaging cluster. Those are the fluoro measure and the nuclear medicine measure. So CMS found 3 claims that Dr. Alexander submitted with denominator codes in measure 145. That's reporting exposure, fluoro time, or dose. But since the threshold for accountable reporting is less than 15 in Dr. Alexander's case for the 12-month reporting period, he would not be held responsible for reporting 145 and would be considered incentive eligible and receive a PQRS bonus for 2013. Okay, so I've talked about measures clusters and measures groups. What is the difference in that? So a measures group is a CMS identified group of clinically related measures for reporting through claims-based or registry-based submission. The denominators for the measures are a similar patient population. There's 22 measures grouped in 2013, such as the chronic kidney disease, oncology, preventive care, and back pain. Interventional radiologists may be able to report the perioperative group, and ROs may be able to report the oncology group. A cluster, measured cluster, is only used for the purpose of determining satisfactory reporting. You can't report on a measured cluster, and measures in a cluster may have denominator populations that are entirely different. So let's now look at how you would report using a PQRS qualified registry. Some of the benefits of registry reporting include that you can submit your data throughout the year, or you can wait to the very end of the year all the way up to the March of the following the end of the reporting year. Typically, registries will give you ongoing, timely feedback on your reporting rates and, in many cases, on your performance. Historically, the success rate for the PQRS incentive has been higher using registry reporting. However, in 2011, CMS reduced the requirement for claims-based reporting to 50% rather than 80%, so we did see a jump in successful claims reporting in 2012. So to begin reporting using a registry, you still need to start with the same basic process that you would with claims. You need to figure out a flow within the practice so that the radiologist knows which cases to report or meet the measure performance requirements, and a way to indicate to staff that those cases should be flagged for reporting quality data through the registry. A registry may allow online data, manual data entry, or submission of files in multiple formats of the quality data. In order to use a registry, you have to be able to report at least 3 measures or a measures group. For individual physicians can report measures groups. So now let's look at a measure and sample reporting for that measure. We'll walk through the fluoroscopy measure, which is titled Exposure Time Reported for Procedures Using Fluoro. The measure is a percentage of final reports for procedures using fluoroscopy that include documentation of radiation exposure amount, if that is known, or exposure time. These are all the denominator codes for fluoroscopy, because there are so many exams that use fluoroscopy that this is a measure that does have quite a substantial number of CPTII codes as the basis for reporting. And I'd also just like to note that these are procedures which always use fluoro. So what you would be reporting for that measure, for any of the exams that we saw in the denominator, you would report a CPTII code that says either you documented radiation exposure time in the final report or you didn't. So 6045F is the CPT quality data code for reporting measure 145. And with the 8P modifier, you are saying that you did not do what the measure asked you to do. So each measure may have a number of exclusions which are denoted by a CPTII modifier that you would find in the measure specification. So not all measures have a specified reason for excluding patients from reporting. The modifiers are 1P, medical reason, 2P, patient reason, and 3P, system reason. As we saw in the fluoro example, reason not specified is 8P. The fluoro measure didn't have a specified reason, but you can still report 8P, which is basically saying you didn't do what the measure asked you to do, and still get credit for reporting. Just to remember that it is a reporting program, not a performance-based program at this time, so you can report that you didn't do what the measure asked and still receive an incentive. So let's walk through satisfactory reporting on measure 145. So let's say Mr. Jones comes in and has a procedure using fluoro. The CPT code for that procedure is in the denominator of measure 145. You can either report quality data code 6045F, saying that you documented exposure or exposure time, or that you did not document exposure time with the 8P modifier and still be considered satisfactory reporting. So that was satisfactory reporting for that measure. Now let's look at satisfactory reporting for the program itself for incentive payment using claims as an individual physician. As I said earlier, you can report less than 3 measures and still be incentive eligible. So if you report 1 or 2 measures for 50% of applicable cases for Part B fee-for-service patients for a 12-month period, and you successfully go through the measure applicability validation process, then you would be incentive eligible. If you report more than 3 measures, or if you're able to report 3 or more measures, and report on 3 measures for 50% of all applicable patients or cases for a 12-month period, you would be incentive eligible. Or if you report 1 measures group for 20 applicable patients for the 12-month period, you would be incentive eligible. And also please note that you cannot report a 0% performance rate and have that measure be considered satisfactorily reported. For satisfactory reporting for the incentive payment using a registry for individual physicians, if you report individual measures, you must submit 3 individual measures on 80% of applicable cases for the 12-month period. If you're reporting measures groups, you can either submit a measures group for 20 applicable patients, 11 of which must be Medicare patients for a 12-month period, or you can submit that in that same way for a 6-month period, July through December. And if you report for the 6-month period, your incentive will be based on the total allowable charges for that 6-month period. Successful reporting for the incentive payment using the group practice option, the GPRO option. Again, it must be a group of 2 or more eligible professionals who have self-nominated as attend to CMS. You report either using the registry-based reporting of any of the measures in the PQRS list, or for non-radiologists, they may use a web interface, and the measures that are reported through the web interface are basically primary care measures. So if you submit 3 individual measures on 80% of the group's applicable patients for those measures for a 12-month period, the entire group would be incentive eligible based on their total allowable charges, whether or not every physician in the group had cases that were reported on. Now, let's talk a little bit about the PQRS Maintenance of Certification Additional Incentive, which is a 0.5% incentive on total allowable Medicare charges above the 0.5% PQRS incentive. This began in 2011 and is currently authorized through 2014. To be eligible for the additional incentive, you must first satisfactorily submit data on PQRS measures and be incentive eligible for a 12-month period, and participate in a qualified MOC program more frequently than is required for continued certification. You need to work with a CMS qualified MOC entity, a board such as the ABR or ABNM, to ensure that you're completing participation requirements more frequently than required for your certification. I hesitated to show you this slide because I'm afraid it will confuse you, but I just wanted to point out that what more frequently is considered, was considered in 2012. I can't show you 2013 yet because CMS has not yet said what, has not yet qualified boards for 2013 more frequently. So for 2012, basically what more frequently was, you would find in the Part 2, Lifelong Learning and Self-Assessment, and Part 4, Practice Quality Improvement. So what would be more frequently is that your Cat 1 CME credits and your self-assessment credits are above what is required for maintenance of certification, for continued certification. And a practice quality improvement project, one must be completed in the 12-month reporting period. Also, a patient experience of care survey must be performed during the reporting period. And if you would like more information, I know you can contact the ABR to get additional information on and look for their announcements of 2013 PQRS incentive. So we've talked about how to satisfactorily be incentive eligible for the PQRS incentive. Now let's look at how the 3 ways that you can avoid the payment adjustment in 2015. First of all, if you meet the criteria for the incentive, then you're automatically will not be assessed, evaluated for a payment adjustment. If you report in 2013, if you report 1 applicable measure on 1 patient, or for individual physicians, you report 1 measures group on 1 patient, you will avoid the payment adjustment in 2015. Or as I said earlier, you may elect to be analyzed under the administrative claims option, and you must do that by October 15th. So this is for 2013 reporting for the 2015 payment adjustment, and I would expect to see this more strict in 2014 for 2016 payment adjustment. I won't go through all of these just so I can leave enough time for questions, but I do want to highlight a couple of things in terms of payment adjustment analysis. The payment adjustment may be applied to each unsuccessful tax ID and PI combination. So if you're an individual physician that bills under more than 110, you will be assessed separately for each of those tax ID and PI combinations for the payment adjustment. And this also applies to incentive eligibility also. So you might actually obtain an incentive under 1 tax ID number and have a penalty under another. And if you're reporting as a group under the GPRO option, if your group does not successfully report all individuals and PIs under that tax ID number during the unsuccessful reporting period, will receive a penalty or conversely an incentive if you're successful. So if your group does not successfully report in 2013, then in 2015 the payment adjustment of 1.5% will be applied to all the billings for your practice for Medicare Part B. The bonus payment and feedback reports that are provide you with information on your experience for the reporting period. Actually, in beginning last year, CMS started an interim feedback dashboard, which will give you the ability to monitor status of your claims-based reporting. This is only for claims-based reporting. It will display on a cumulative quarterly basis the most current data of what you have reported. It provides detail at the tax ID and NPI level, and only gives you reporting rate information on quality data codes that you have submitted accurately. It doesn't give you performance rate information. You can access the interim feedback dashboard through your IACS account. You must register for that account. And it does not provide a final analysis for incentive eligibility. That is done, the incentive analysis begins at the end of March following the reporting year. That allows for a claims runoff. The incentive bonus, if you are eligible, is paid in an October time frame. So for 2013 reporting, the incentive would be paid in October of 2014, and that check would go to your carrier. The feedback reports that give you information on both your reporting rate and your performance rate are also available in that October time frame. So if you don't understand or disagree with your PQRS determination, CMS has developed an informal review process which allows you to request reanalysis of their determination. You can request this through an online tool which will be announced sometime in the end of the year that it's available for requesting a review. The deadline for 2013 request for analysis is will probably be around February 2014. So quick overview again what the impact of PQRS 2013 is. There is still a 0.5% incentive, PQRS incentive this year with additional 0.5% for MOC. There's a potential for a negative 1.5% penalty for an individual that does not participate by reporting at least one measure. And also 2013 participation is the basis for the physician value-based payment modifier for groups of 100 or more. So I just wanted to let you know that part 2 of this webinar series, sometime this summer, we will present you with information on the value-based payment modifier. Also just announced there is a CMS National Provider Call on June 15th that will talk about the value-based payment modifier, and you can register for that call at the link given here. And as I said, there will be a recording of today's webinar on this web page. Here for your reference is a list of abbreviations that we use today and resources that you can use, hopefully, to answer your questions. And if there's any questions now, we will address those.
There are a great number of questions, so I'm just going to go through them in order in which we received them. And some of them may have been addressed as part of the presentation, but we'll go over them anyway just to be absolutely sure they were answered. A number of you asked if the slides would be emailed to you. We will email the links to the recording as a follow-up to this email, and you will have them. Okay, the first question. Why are some measures reportable only by registry, such as biopsy follow-up?
It depends on the measure, but in many cases it is based on the clinical data that is needed for reporting, so that there has been some difficulty in developing a claims-based specification in order to gather the data that is needed for the measure.
Okay. Is there a specific number of measures a provider must report on to qualify for PQRS?
Yes. You must report on 3 measures if there are 3 measures that are applicable to your practice. If there's not, then you may report on 1 or 2, but you would be subject to the measure applicability validation process. And you can only report less than 3 measures using claims-based mechanisms.
And I guess the next question follows up on that. If providers cannot meet any PQRS measures, can they be exempt?
There is no formal exemption from PQRS, but there are a couple of options that could address that. One is to elect the administrative claims-based option. That's for 2013 and for 2015 payment adjustment. Or your group might consider reporting under the GPRO option. IDTF
providers are not eligible to report PQRS from my past research due to lack of clinical information. Is this correct?
That is correct, and that's primarily because they are not considered as an eligible professional. They are not an individual physician, and it has to do with the mechanism for billing.
If we use group reporting of 3 measures, will the 0.5% bonus apply to all group Medicare billing, even if only some of the radiologists meet all 3 measures?
Yes, that's correct.
Okay. Since original claims must have QDC, is it too late this year to start to use claims reporting for radiology?
For reporting 2013, it is not too late. Since we're in May, and for claims-based reporting, the requirement is 50% of all your cases. So potentially it may not be too late if you haven't reached 50% of your cases for the 2013 reporting year. So it's not too late to get started. And in any case, you would avoid the payment adjustment if you started reporting now using claims.
Can I choose my own 4 clinically related measures to report as a measures group?
No, it has to be a measures group identified as such by CMS. And I'm sorry, you can find a list of the measures groups that are available for reporting either on the ACR web pages, the links I gave you in this previous slide. You can find that information, or on the CMS website under the measures group specification manual.
For fluoroscopy time, do you need exact times used or estimates, such as less than 1 minute was used?
That would be acceptable.
Does this reporting need to be done on Medicare replacement plans? Are there incentive payments or penalties for Medicare replacement plans?
Medicare replacement plans. It is Medicare Part B fee-for-service. I'm not sure exactly what replacement plans are, but if they are considered fee-for-service patients, then that would be acceptable to report on.
I know it is not the case now, but is there an expectation that performance will be penalized in the future? For example, HP is applied to 80% of the claims reported.
That is where the physician value-based payment modifier comes in. That program will be looking at performance rates and provide for quality tiering plus or minus reimbursement based on performance rates comparatively.
When will we know the PQRS MOC incentive requirements? Will it not be until the fall?
I think it should be out relatively soon. It's usually been in April or May of the year that that's been posted. So I would expect to see that soon.
We report individual unclaimed basis for our radiologists. Not all of them perform the three measures we report on, 146, 147, 225, just the NUCMED doctors and mammographers. Will this hurt our reporting status? Should I start now to report measure 145 to include our IR doctors? Are there any measures for radiologists that only read diagnostic X-ray, CT, or MRI?
Well, that's a lot of questions. Yeah. So I'll just say that if the individual physician can only report one measure, and that is in a measure cluster, you need to look at the other measures in that cluster to make sure that radiologists couldn't have reported other measures in that cluster. If they report a measure that is not in a cluster, for example, the measure 76 CVC placement that a number of interventionalists can report, that if that measure is reported alone, it is basically a standalone measure, and you would not be subject to the measure applicability validation process. So I'm not sure if I've answered that question, so you feel free to contact me later if I haven't.
Are there any measures for radiologists that read only X-ray, CT, or MRI?
X-ray, CT, or MRI. Well, those might be the fluoro measure. I don't know if your X-ray is including screening mammography, but that potentially could be one that you would report. But, and again, I'll point out that next year in 2014, a set of 5 measures, which right now has been finalized as a measures group, has been finalized for 2014 reporting, and those focus on basically on CT exams.
We have different responses to the issue of whether PQRS is reported for only traditional Medicare Part B fee-for-service patients, or if it is to be reported for Medicare HMO Advantage programs, etc. We are in claims-based reporting.
No, Medicare Advantage is not, those patients are not reported on. There's some confusion about how that works with Medicare Advantage plans, and it's really the individual's contract that you have with the Advantage plan. Some may pass through a PQRS incentive to you, but it's your individual contract with the Medicare Advantage. But it would not, you would not be incentive eligible through CMS fee-for-service program for that.
How would CMS know if a radiologist is in MOC?
That is one of the things that the boards who are qualified entities have said to CMS, that they would report information on behalf of the physicians to CMS. So if you go to the, for example, the ABR website, you can see through your My ABR tool, you can request ABR to submit data for you to CMS for the PQRS MOC additional incentive.
What is the actual process for electing the administrative claims option?
Well, I don't know exactly yet because the website, CMS has not opened up that website yet, that web portal yet. But, and there will be information on both the ACR web pages and the CMS PQRS web pages on how to do that. But you will go onto the web portal, identify yourself through tax ID and NPI, and elect to have your claims evaluated. So it is a proactive process. Can't really tell you much more about it then except to look for an announcement about that web portal being live.
Does the measure for the reminder system for mammography have to be documented in the final report?
No, it doesn't. The measure just states that you have a reminder system that includes certain pieces of elements to it, like patient demographics, that allows for reminder letters to go to the patient. And I would recommend that your practice has a written policy or procedure that says your patients are their patients' information are entered into that system as a written policy, and that should serve for audit purposes.
If you submit a claim that is split between two HCFAs and both contain the same CPT code that qualify for a PQRS code, do you report the PQRS twice? Once for each HCFA, for example, 75726 with 6045F and 75726 with 6045F on HCFA 1 and HCFA 2.
That's a good question.
I was reading it right.
I have to think about that and research it a little bit. So if whoever asked that question could contact me, then I'll work through that with you.
Okay. Are there other parameters or possible projects that can be performed other than the ones that you mentioned?
Not this year, but as I was saying earlier, that is what CMS is looking at now, and that's what the fiscal cliff legislation authorized to allow CMS to do. So I think that's very encouraging for future years that potentially specialty society registries such as the ACR, Numerator registries, Dose Index Registry, and others, or maintenance of certification, practice quality improvement projects may be considered quality initiatives, and potentially in the future those may be considered, participation in those may be considered as PQRS participation, but there's a lot to work out yet, so that's in the future.
Can you please go over the interim feedback dashboard again and how to use it?
Yes. Go back to that slide. I did go through that rather fast. The first thing, if you haven't registered for the CMS computer system, that's called your IACS account, you need to register that, and then the same website that you registered for that will give you access to the interim feedback dashboard. There's more information on accessing that on the CMS PQRS web pages. I don't know. I don't have that a link to that direct page, but there is. If you would look on the PQRS web pages at the main PQRS page on the left-hand side, it will say Analysis and Payment, and that is the sub-page that would give you more information on the interim feedback report.
Please repeat the ACR recommended registry company that you mentioned.
The vendor is CE City, and their product is called PQRI Wizard. You can see more information about that on the ACR web pages shown here. If you go to the quality measurement page, and there should be a box on the right-hand side that would link you to the ACR PQRI Wizard.
For the patient care experience survey required for MOC, would a hospital patient satisfaction survey count?
If that's information on the individual physician or the physician group, it should. There are, the ABR website does indicate several survey tools that can be used, so I would check that too.
Is the dashboard to view your PQRS status located on the CMS website?
The information on how to access that is on the CMS PQRS web pages. I believe that takes you to the QualityNet website. But there is a link from the CMS PQRS page to that.
We have two companies, each with its own tax ID number. In one entity, the radiologists meet 3 measures, but in the other, they meet none. What happens to this if we do claims-based reporting?
Well, I think you might want to look at the administrative claim space option for this year for that tax ID, so that those billings would not be subject to the payment adjustment.
For a group practice, we already report PQRS, but are we supposed to separately register on CMS? If so, we can only do that in July?
Wait, can you repeat that?
Yeah. For a group practice, we already report PQRS, but are we supposed to separately register on CMS?
Well, I just want to make sure that when you say as a group you are reporting, do you mean that you have self-nominated to CMS as a group under the GPRO option, or you're considering yourself reporting as a group because everyone in your group is reporting the same measures? That's not the same thing. So if you want to be considered as a group under the GPRO option, you have to self-nominate to CMS by October 15th.
If original claims submitted earlier this year did not contain CQM, can these prior claims be reported via registry-based reporting?
Yes. You can use a registry report. You can start reporting by registry on March 15th of 2014 and go all the way back to January 1st, 2013. But you would need to think about whether or not you've done the actions that the measure is looking for you to do. In some cases, you may, such as a reminder system for mammogram. If you have that set up in your practice on January 1st and you wait till March 15th, 2014 to report that, then you could probably report that you did that measure. But in some cases, you may just be reporting that you didn't do the action.
Can fluorotime exposure be documented in the patient's medical record, or does it have to be on the radiologist's dictated report?
The specifications for that measure say final radiology report. Okay. And if that is if the electronic medical record is where that report is located, then I would say yes.
If I want to use the registry option, is it too late to submit data for this year?
For 2013, no, not at all.
Can I report measure 146 and 225 on the same claim?
If you have for the same patient, the CPTII codes or diagnosis codes for both those measures on the same claim, then yes, you can report the quality data codes for both of those measures on that claim.
If a radiologist is part of the group with the same TIN, claims-based reporting, and specializes in mammography and does not rate other cases, would reporting only on one measure 225 be sufficient, or do they have to report on all 4 measures that are available to the whole group in order to get the incentive?
If they report the measure 225 reminder system for mammogram, they should be able to report measure 146, inappropriate use of BI-RADS 3. And both of those measures are in the diagnostic imaging measure cluster. So if they only report 225 and not 146, then when they undergo the measure applicability validation process, they will be considered not satisfactory reporting for 146.
If a radiologist performs an intraoperative reading, is both the surgeon and the radiologist to report on the fluoroscopy measure?
That's tricky because it is who bills for it. So if the radiologist bills for that, then yes, they should report that measure. If the surgeon also bills for it, then they would report the measure.
What are the measures for breast imaging only practices?
That would be 146, the inappropriate use of BI-RADS 3, and 225 reminder system for mammograms.
We are pro-fee for mammography. Do we have to report the reminder letter, or is this the responsibility of the facility?
Say that again.
The reminder letter, Oh, yeah, we are a professional fee for mammography, so I assume it's just a physician group. Do we have to report the reminder letter, or is this the responsibility of the facility that does the technical portion of the program?
No. If you're billing for PC only or global, then you can report the measure and should.
I think this is a follow-up to our previous questions. I'm just going to read it out anyway. Our type of provider must register even if we aren't eligible to report.
What?
So I guess if a provider is not eligible to report for any PQRS measure, should they still register?
If there's no measures that they can report, then they should elect to be analyzed under the administrative claims-based option.
Last question. Our interventional radiologists have filed the ERX hardship exemption for 2012. Do I have to file again for each radiologist for reporting year 2013?
Didn't someone just send me that email? Yes, you should. Well, so that's a tricky question. So, and there's a lot to that, but most radiologists aren't really eligible for the EXR measure. It's based on E&M codes in that measure. And there are two requirements also for the measure. Is that you have at least 100 cases that have those evaluation and management codes, and greater than 10% of your billing comes from those codes. So if you pass through that, then you are eligible for the measure, and you would need to submit a hardship exemption if you want to be excluded from the potential penalty. If you don't meet those thresholds, then you shouldn't have to do an exemption. You're just excluded because you're not eligible. But you should contact the Quality Net help desk about that if you have an issue with it, or call me if you want.
We had one more person who wrote in asking if the recording would be available as well. Yes. There will be instructions on how to access the slides and how to access the taped audio as part of the follow-up email to this webinar. So all of you who are on this webinar list will get that information. Thank you so much for attending.
Yes, thank you very much. Have a good afternoon.